Good evening and welcome to the Long COVID Clinic, What You Can Do, with me, Dr. Binita Kane, and
me, Helen Oakleigh, advocate and founding member of charity Long COVID Support, patient advocate and filmmaker.
And we're really excited to have another fireside chat this evening with an amazing guest who I will introduce in just a second. Can't get my words out tonight. Don't forget, the session is live and interactive, so please pop your comments in the chat. Helen, as usual, will be backstage keeping an eye on comments and generally keeping the order of things. So I'll pop you backstage now, Helen, and I will bring on our wonderful guest. Delighted to introduce Dr. Tania Dempsey. Now, Tania is a world-renowned expert in chronic disease, autoimmune disorders, and mast cell activation syndrome. She's the founder of the AIM Center for Personalized Medicine in New York, which uses integrated medicine to get to the root causes of illness and help patients to heal. So welcome, Tania. It's really excited to have you on.
Oh, I'm excited to be here. Thank you for having me.
Now, having looked at your repertoire, I think we could probably have 16 of these sessions and not cover everything I want to talk to you about. But tonight we're going to focus on mast cell activation. And I wondered whether we could start with you just briefly telling me about your journey to how you sort of got interested in this kind of medicine.
Yeah, I guess it's been an interesting journey. Some of it is my own interaction with patients as a primary care provider and sort of being frustrated by the system. Some of it is my own journey with always wanting to be as healthy as I could be, feel as good. You know, I did bodybuilding in med school and continued to work out. I was always interested in diet. I was always interested in our overall health. How can we live our best life? And at some point, it was really hard to reconcile the way I lived my life with what I had to do with my patients and what I was required to do in a standard, traditional, conventional medical system. You know, throwing medications at people, spending 10 minutes with people, only dealing with one problem at a time. And I wanted to be able to give patients the time that they deserved, the attention they deserved, and to help them put the pieces together, finally, to make sense of what they're feeling, what they're going through, and then find, you know, the root causes of that, and then give them a path to be on. And so it was a sort of a slow evolution. But then once I kind of understood that I had to go this direction and realized that there was a whole field of integrative medicine, functional medicine out there, it just sort of like, you know, you can't kind of unsee what you see. So then I left my conventional practice and went on my own. And that was about almost 14 years ago. So,
yeah. And I am probably about 5 years into that journey, but probably only just at that stage where I'm kind of like, I really don't feel connected with conventional medicine anymore. So even though I do practice it still, I'm very much going on that same journey. So everything you've just said is really resonating with me.
But just to be clear, I'm still very conventional in many ways. I'm a real doctor. You know, I do think, you know, patients need testing, patients need medication. So I think there are integrative practitioners out there who have just gone maybe like really far in the other direction, that everything is natural. I think what's really important is that we have, this is the 21st century. We have amazing tools and amazing resources and medications and testing and things like that. But we need to know how to balance it with the other stuff, right? And I think that's kind of like missed out on by some people.
That's where conventional medicine really fails. I think that we are just focused on the drugs and the tests, and that is clearly really important, but there is a whole world of other stuff.
That's right.
Okay, so tonight we're going to talk about mast cell activation, and I really want to take this back to the basics. So let's just start by talking about what are mast cells and, you know, why are they important in health?
So mast cells are white blood cells, actually, and they are part of the primitive immune system. We have various parts of our immune system, and the mast cells are part of the part of the immune system that reacts very, very quickly to things that are foreign to it. So the mast cells are going to react to viruses, bacteria, parasites, chemicals, anything that's foreign to the body. The mast cells are our first line of defense. And they are the type of white blood cell that's found in tissue, as opposed to, a lot of people think of white blood cells as being in the bloodstream, but mast cells are in all your tissue, in all your organs, in your blood vessels, not in the bloodstream. And so they're positioned in all the places where they're in direct contact with the environment. So there are tons of mast cells in the skin, for instance. There are tons of mast cells in the respiratory tract, right? Breathing in the air, touching the air, in the GI tract, right? Where you're eating and you're potentially being exposed to various, bacteria or parasites or other things. So they're important to us for that reason. But I think that if we look at like evolution, I think mast cells were there, again, to protect us from all these things. But fast forward to the 21st century, they're really kind of reacting to like a lot of things, because our whole environment is really kind of toxic, right? There's constantly things that are foreign to our body that they have to react to. And so the way I think about it is that everybody has mast cells, and there are going to be people whose mast cells are, we'll call it well-behaved. They react when they have to react. They get I guess they get in contact with, let's even just say the COVID virus, SARS-CoV-2. They see that virus, they react, they talk to other white blood cells, other parts of the immune system. They initiate this attack, and then the virus goes away, and then the immune system resets, and now it's just ready for the next attack. Okay, that's kind of what mast cells are supposed to do. In patients who have mast cell activation syndrome, what happens is that these mast cells are primed to overreact. And we can talk about why they're primed, because we have some theories about that. But let's just say there's a subset of people, and we think that number is somewhere around 17% of the population, based on a study that was done in Germany, have dysfunctional mast cells that they may be aware of or not. And these dysfunctional mast cells are always reacting a little bit at baseline. And one of the ways they react is they explode and they release various chemicals. Histamine is one that a lot of people have heard of, but there are over 1,200 different chemicals that mast cells can make and release. And these chemicals, in a mast cell patient, an MCAS patient, is sort of like they have a baseline low level of stuff that's just simmering, causing some inflammation. Then they have a major event like SARS-CoV-2 infection. And then these dysfunctional mast cells, you have to kick into gear. They start to fight. But because they were already sort of fighting and not fighting well, they become overreactive. They cause the rest of the immune system to overreact. So then you get this sort of this like cytokine storm, kind of thing. And then it takes a really long time for them to reset. And they may not reset completely, which is why a lot of people continue to have symptoms, because they're now that low level of release of these mediators becomes a higher level. And over time, every exposure becomes a little bit more and a little bit more. So I'll say that mast cells are involved in allergy. We know that there are people who are just allergic to things. That's a mast cell condition. But having an allergy doesn't mean that you have MCAS. And having MCAS doesn't mean that you have an allergy. You can have mast cell symptoms without allergic symptoms. You can have allergy without MCAS. But I think that like a lot of people have heard of allergies, like to pollen and to food and things like that, and they don't realize that actually it's rooted in the mast cell releasing histamine when it sees those various triggers.
Absolutely, and I definitely see in my clinic to this idea that people have these simmering mast cells in the background, whether they know it or not. I see people with, a little bit of asthma, they've had hay fever, they've had a little bit of bladder, interstitial cystitis, they've had some gut issues, maybe some IBS type issues in their past, and then COVID's come along, and then they've developed this mast cell, and I see that over and over and over again in my clinic, and I think it's a real risk factor. So just getting back to the basics of mast cells, then kind of the typical response, protective, they should be protective. So a wasp sting or an insect sting or, an something like an asthma attack can all be mast cell. That might be things that people are familiar with. And mast cell activation is when this becomes, when you're starting to react to things you shouldn't react to. So that's, I think, just to clarify that. Okay. So getting a diagnosis is really difficult in the UK because we're really wedded to these strict guidelines and tests that aren't available generally or aren't very good, particularly. So and also the fact that I see in my clinical practice that MCAS is a spectrum, like from normal to full-blown mast cell activation syndrome, where people have the rashes and the asthma, and it's very obviously allergy related. But there's this whole kind of spectrum in between that I think responds to treatment, and people are often denied treatment because they don't fit certain boxes and criteria. So I'd love to get your thoughts on diagnosis and labels and who we should be treating.
So when I first, I'll use the term discovered or really started to understand MCAS, and started to work with Dr. Lawrence Afrin, who's really one of the leaders in the field of MCAS. And we worked together, we published together. Especially in the beginning stages of our work, I was pretty wedded to the fact that patients really need a diagnosis. And so we need to do whatever we can to measure the mediators that are being released from the mast cell as best we can to see if they truly have mast cell activation syndrome. And I've changed my stance on this a little bit because of the difficulties in mainly other countries, but even in the US, there are lots of difficulties in doing the testing. What I would say is that, we published a paper at this point, probably 4 years ago, called it was basically how to diagnose consensus using the consensus 2 criteria for mast cell activation syndrome. There is a consensus 1 group that feels very strongly about the use of tryptase as a measure of mast cell activation syndrome. And in that paper, we go through why tryptase is not necessarily a good measure of mast cell activation syndrome. It may indicate other problems, but it's not great for the diagnosis. And we go through ways that you can make the diagnosis and including the clinical diagnosis, right? So sure, it would be best if you could find 2 mediators, 2 different things that the mast cells make, whether it's histamine or heparin or methylhistamine or leukotrienes. There are lots of things that you can test for, and there are lots of things you can't test for. Mast cells make 1,200 different mediators, and we can only test for a handful. But that's the way you diagnose it, is that if they're releasing these mediators, then you must have abnormal mast cell activation. If there are no mediators, then you don't have it. But the problem is that these mediators are very thermolabile, which means that they're very heat sensitive. And they're very, very transient in the blood and in the urine. So the specimens have to be handled very, very carefully and correctly by the patient, by the lab. And so sometimes we don't find the mediator, even though the patient has it. So, depending on who you talk to, some people will treat the patient without the testing based on their response to the treatment, right? That can be sometimes helpful. Where it's not helpful is the patients who you really struggle with finding a treatment and they don't necessarily respond to standard antihistamines or some standard other things. And you have to move on to stronger, more aggressive treatments. If you don't have a diagnosis, then you start to doubt that you're even barking up the right tree. And
Yeah.
it may very well be MCAS, but if you don't prove it, you're kind of limited by what you can do, right? So that's the downside of not trying to find the answer. The other way you can make a diagnosis is by examining biopsy samples and using a special stain called the CD117 stain. So a lot of patients in the US, I don't know how it is in the UK, but lots of patients who have had a lot of GI symptoms have been scoped. They've had colonoscopies or endoscopies. They've had biopsies. You can request those biopsies, send them to a pathologist who's willing to work with you, and they can restain them for the CD117, which is a very specific stain for mast cells. And then you count the number of mast cells. And if you have more mast cells in a specimen, that can help also with a diagnosis. So for some people who we can't find the mediators in their blood or in their urine, but we find that they have more mast cells on a specimen, that is confirmatory and helpful, again, as we're trying to figure out how to treat. But it's definitely a challenge, and I wish I had a easier answer for that.
Yeah, I mean, we have access to nothing in the UK. Pretty much, it's impossible to get these. You're very lucky if you can get 24-hour urinary prostaglandins checked, or even tryptase being checked is very challenging. So I mostly go on a clinical diagnosis and trials of treatment, just in the absence of anything else, especially outside of you can't get these tests on the NHS. It's even harder, I think, to get them outside of the NHS. So, one of the challenges. Go on.
Oh, sorry. No, go ahead.
I was just going to say, one of the challenges of using symptoms as diagnosis is, of course, that they overlap with so many other things, because mast cells are stuffed in every tissue in the body, and they cause this whole range of symptoms that overlaps with POTS and menopause and various other things. So it's not perfect trying to diagnose it without the tests either.
Right. No, exactly. But what I would say is that if you take a really good history and you start at the very beginning of a person's life, and in fact, I would argue that you need to start with the pregnancy or the health of the mother, if you know it. Okay. Yeah. I mean, obviously some patients are adopted, they don't know, but if you know the health of your mother, how that pregnancy went, the early years, and then you walk through that history chronologically, I think it becomes pretty obvious that there were multiple triggers over the course of a lifetime that then brought these dysfunctional mast cells to a certain level. I think you do need an initiating event. The initiating event could have been a pesticide exposure in utero. It could have been a pesticide exposure or a petrochemical or something early in life. It could have been a virus or infection, but there is something that triggers, usually pretty early on, that brings the mast cells to a level that makes the patient more sensitive. And they, over time, they may not even realize they're sensitive. I would call it, maybe they would be called susceptible. And then over time, they become more sensitive, because then each additional exposure brings them out more and more until, there's a really great image that one of my colleagues put together that's like an iceberg, where you see the iceberg sort of break through, and finally, now that the mast cells are on the surface, and now, boom, all the symptoms are out. And I think if you can get that history, through the course of that, I think that's helpful.
Super. No, thank you. Okay, I'm just suddenly conscious we're already 20 minutes in. So let's move on to treatment. So can you talk us through your kind of stepwise approach to patients?
Step one is you do have to eliminate triggers, and you have to identify triggers. And sometimes those triggers are obvious, and sometimes they're not in the least bit obvious. And so that's what we work with the patients on initially. Sometimes, yes, we're initiating treatment also, but if they're being exposed to something, if they're living in a moldy home and you're trying to treat them with antihistamines or anything else, it's not going to work. I mean, it might help a little bit, but then they're going to break through, right? So, because I see people like asking, about, they're using a drug and it stops working, right? So you always have to think about why. And so sometimes there are things in the environment that you have to look at that are triggers. Sometimes people don't realize there's mold, but it may not even be mold. It could be formaldehyde. It could be some other chemical. It could be cleaning products. It could be personal care products. It could be implants or mesh that was put in for a hernia repair, or it could be a piece of metal that was needed after surgery to hold something together inside your body. There's so many triggers, but you need to kind of walk through and figure out, is it possible that any of those can be eliminated? Sometimes you can't, but some things are you're able to eliminate, right? And so step one is always figure out the triggers and eliminate. It could be a new medication that somebody put you on for another condition that has a excipient in there, a chemical in that medication that's causing a problem, right? So you've got to walk through that. And then as you're working on that, then, typically I'll start with an antihistamine. Now, the antihistamine can be a drug. And in the United States, we have a number that you also have in the UK. There's some overlap with some of the things that we have. And then we have some that you don't have. But a typical, H1 blocker, loratadine, cetirizine, there are a bunch of them, diphenhydramine. You start and you work through one by one to see if there's any reaction, to see if there's any, effect, positive effect. Sometimes we trial the natural antihistamines, vitamin C, quercetin. There are a variety of compounds that also have natural antihistamine properties. Then we move on. There's another class of type of antihistamine called the H2 blockers. And sometimes combined with the H1 blocker, that can be very helpful, very synergistic. These H blockers are histamine blockers. So if the mast cell is releasing histamine, these agents block the receptors so that the histamine can't bind to the cell and cause a problem. It also helps and kind of binds to the mast cells and tells the mast cells, hey, calm down, stop releasing so much histamine. So there's a little bit of a negative feedback loop also, which can be helpful. But some people don't have histamine as a problem. Again, mast cells can make over 1,200 different chemicals. I have patients where histamine is not the problem. And it's another chemical that's the problem. So the antihistamines may, in fact, not do anything. And so, but you have to figure that out. In the vast majority of people, they'll get some benefit from the antihistamine. Sometimes they have to be rotated. Sometimes they have to be compounded. There are nuances to that. But then there are a variety of other agents that can be used to stabilize mast cells, to block the effects of the release of those mediators. And really there are, lots of things that can be used, right? I don't know if we want to go through every single one, but, there are a lot of options.
Yeah, I mean, the main ones that we sort of have ready access to here is ketotifen, sodium chromoglycate, montelukast. We don't really have access to biologics, really, unless you fit one of the criteria like asthma or urticaria. But those would be the sort of the main ones that we would use over here. I'm sure you've got different things you use in the States as well.
Yeah, and the other thing that I think can be helpful for the right patient is low dose naltrexone. I don't know if you have access to that.
We do use that. Yeah,
that can be.
And what about low histamine diets? Because they are really miserable to adhere to. What do you find that you have much benefit?
I have a post I did on my website and my blog. I have a whole blog on this topic. And what I always say about diet is that it depends. There's no right diet for everyone. And there are definitely people who have figured out their trigger foods. And some of those trigger foods may be high in histamine. But I don't think that the majority of people need to be on a strict low histamine diet. I think you just need to work through it. Elimination diets are helpful in trying to pinpoint it. I think that lower carbohydrate diets tend to be better. There is a link between mast cell activation syndrome and insulin resistance. It's a very huge link. And so there can be a lot of hyperglycemia, high blood sugar, low blood sugar, hypoglycemia. So what I find actually is that lower carbohydrate diets are inherently better for mast cell patients. But if patients are really sensitive to a lot of food, they may be limited by what they can eat, right? So I can't be more restrictive, but we're working towards that, where I think that's going to be better for their health overall. So yeah, I don't typically say to patients, you need to follow this diet and this is going to help you. It's working with them to figure out what form of a diet is going to be right for them. And there are patients where salicylates are more problematic than histamine. And there are patients where oxalates are more problematic than salicylates or histamine. And sometimes it's the histamine and the oxalates. And so, yeah, I wish it was so easy, but actually low histamine diets are not easy. It's really personalized, which is why I called my center personalized medicine.
Yeah, and I think that's really difficult, because I think we are so kind of tied to guideline-driven medicine as well, like in conventional medicine, that personalizing to that degree is really hard. That's really interesting about the insulin resistance, because that's something I didn't know actually. So that I will definitely be going away and looking that up.
Yeah, there's some really interesting mouse and rat studies on this, and some human studies that are sort of going to be coming out, but we're working on our own study, our own case report that hopefully we'll publish in the next 6 months, that will review some of this as well. So yeah, there's a link between MCAS and many chronic illnesses actually that are thought of as separate problems but are overlapped, like high blood pressure, metabolic syndrome in general, high cholesterol. Those things all seem to be actually probably rooted in MCAS to some degree.
And I have a number of patients who it becomes quite hard to treat them because they keep reacting to excipients and different medications. Is there any particular formulations that I know that's a really broad question, and you're going to go, no, it's personalized, but are there any patterns that you've found? Because I have some patients go, I can't take orange tablets because I react to the orange, and of course they say that to some conventional doctors. I think they've gone crackers. But it's a real thing, and it makes it hard because I've got no control over what type of tablets they're going to get when you prescribe them.
I know. And we have it a little easier here because we can compound a lot of those drugs. And compounding basically, is the powder, is the pure powder. And then we can tell the pharmacy, mix it with this filler, but don't put this filler, don't put dye, don't put. So yeah, so a lot of like give you an example, like loratadine. I have lots of patients who try the over-the-counter. Here it's Claritin, and they have problems with it. And we say, all right, you know what? Let's see if we can compound it, eliminate the excipients, and see if how you do. And then all of a sudden they're doing great, and you're like, oh gosh, okay. So that does help us figure out, okay, if we look at the ingredient list of the drugs that they took, and we match it with other drugs that they took that also they reacted to, you could start to see, I have patients who have put together spreadsheets to try to figure out the chemical that goes across, the board, and that's what they're reacting to. Because sometimes it's obviously a dye, like, oh, it's orange or blue or red. But sometimes it's microcrystalline cellulose, and sometimes it's the titanium, and sometimes it's the crospovidone, and sometimes it's the magnesium stearate, and so I really think it's important. It's a lot of work, but for patients to start to see if there's any trend, because then what you can do is you can try again. I think in the UK it's harder, but let's just say, even if you don't compound it, but there are different manufacturers that are making different the same drug. Here, let's say a generic drug may be made by 3 or 4 or more generic companies. You could try to find, the generic company that doesn't have that particular ingredient, and sometimes it works, and sometimes they have all the same ingredients, and then then it's trouble.
Yeah.
So it's not easy. Yeah, and
It's
I
a lot
think
of work.
it's a lot of work. Yeah.
Yeah. Okay. So well, let's move on to the relationship with other kind of issues like POTS, Ehlers-Danlos syndromes, which again we have a real dearth of information about and research, chronic infections, because all of these things overlap, and mast cell activation seems to be common to all of them.
Yeah. So there does seem to be a link. The thought is that the mast cells are playing a role in the autonomic nervous system, driving dysautonomia or POTS. They're in the connective tissue, so they're affecting the integrity of the connective tissue, maybe from the release of their mediators. Maybe it's breaking down, so the connective tissue is maybe stretchier. There's probably some genetic factors, of course, but it does seem that the mast cells are driving this sort of combination of syndromes. I'm working on a documentary right now that actually talks about those 3 syndromes specifically. And the working title right now is Stealth Syndromes. And we talk about MCAS, POTS, and EDS individually and together. And it's a really exciting project. Hopefully the movie will be out in the spring, but we're still in fundraising mode, and we have a trailer. If people want to go to MCAS fund.org, they can watch the trailer. They can donate. It is a nonprofit, and LDN Research Trust has been helping us make this documentary. But I think it's going to be an important documentary to provide a lot of credibility, information that people can share. You can tell your loved ones, here, this is me, watch this. I have all these syndromes. We're trying to normalize this a little bit, right? Because there's so many people suffering. And there needs to be more research. I mean, I say that all the time, but we have a lot of hypotheses, and we have some research that's very suggestive, but we don't have the thing that says absolutely this is 100% for sure. But there does seem to be, definitely.
Yeah. Well, thank you for making that documentary. I mean, the lack of awareness is staggering, absolutely staggering. Yeah. And I think the more we can do, so if anyone wants, we'll put the link under the YouTube video, and definitely check that out, everybody, if you can. So just finally, before we bring Helen back on, I had a question and it just popped out of my head. Oh, no. So I'm going to bring Helen back on because it just popped out of my head, because it will come back to me. It was a really pertinent question.
And I know it's late. It's late where you are, so it's been a long day.
It's not that late.
Okay.
No excuse. I got distracted by the documentary. So Helen, have you got some questions you want to just ask Tania?
Yeah, absolutely. Thank you so much. It's been really helpful, really useful. And we have had a lot of questions come through as well. One of our questions came through from Nikki Perry. And does mast cell change with age?
Maybe. And maybe the answer is probably. I think that there are a couple of things to bring up. One is that mast cells have a lifespan of several years, and so every 3 years or so, there's a new batch of mast cells that are being released from the bone marrow, and so it could be that if you have constant exposures and triggers, that each new batch that comes out is more mutated, more reactive. And so possibly it escalates with time, with age. I don't think it's necessarily a product of the aging process, although I don't know for sure. I think it's more that with time, they're just more exposures. And I think our environment is very toxic, not to go, too depressing here, but like it is extremely toxic. So I think that just inevitably we are, as we're getting older, being exposed to more things. And so I think that we are bringing up our baseline mast cell dysfunction, for a lot of people. So I think that's something to, be aware of. The mast cell dysfunction comes from the mutations that happen at the level of the mast cell. We don't know what the genetics are yet. Like we don't think there's a gene for mast cell activation syndrome, for instance. There may be lots of genes that we carry, but the mast cells themselves have their own genetics. That it's called somatic mutations. And it's those mutations that are dictating what the mast cells are making, what mediators they're making, how they're reacting. And so those can change over time, again, with more and more exposures.
Thank you. I have remembered my question, Helen, if you don't mind me.
No,
just
go for it.
in. It was just a quick one. You mentioned the autonomic nervous system and mast cells, and I know that there is a definite stress response with mast cell activation. I mean, I've seen severe stress bring out urticaria in patients. And is that something you recognize and treat in terms of resetting that, trying to turn off that sympathetic overdrive that a lot of our patients find themselves in?
Absolutely. I think that there are a lot of tools to reset the sympathetic nervous system. I think that trauma is a big issue in general. And so, but doing trauma work, breathing, breath work, limbic retraining, all those things I think can be really, really helpful in bringing the sympathetic drive down. Yeah.
And I think that's relevant for any chronic illness. It's certainly not limited to long COVID or ME. I see that across the board in every chronic illness I treat. So thank you. Go on, Helen. Did you have?
Just to follow on from that, actually, do you think that's like an ongoing thing for the rest of your life that you need to do, or is that kind of a reset thing, and then you can kind of start over in a way? Does that make sense as a question?
Yeah, it's a good question. I think it depends. I think if we go on the premise that people who wind up with chronic illness like MCAS, long COVID, if they're predisposed, right, there's something in early life that predisposed them for their immune system to react this way. My hunch is, and I think it's more than a hunch because I see this patient after patient after patient, I think that they have a dysfunctional autonomic nervous system from a very early age. And when you get the history that I was suggesting from an early age, I think it's very, very clear. We know that, I mentioned earlier, there's a link between insulin resistance and MCAS, and there's a link between polycystic ovarian syndrome and MCAS, and polycystic ovarian syndrome is insulin resistance. Women with polycystic ovarian syndrome, they have insulin resistance, they might have acne, they have irregular periods, they may have fertility issues. They also have increased sympathetic tone, and they have more sympathetic drive. And they know that for a long time until all of a sudden then their asthma acts up, and then they have urticaria, then they have, or they present with long COVID. And so my sense is that it may be healthier for patients to always think about, not obsess over, but like maybe they need to reset things periodically. Maybe it doesn't have to be every single day for the rest of their life, which is overwhelming, but maybe they do a reset, and they see how they do. And maybe it's a reminder, I have patients who, they do well for a while, and then some of the symptoms start to come back and they go, oh yeah, I think I got to go back into it now, So I think for the most part, I think, not to sound pessimistic, but generally speaking, there's no cure, right? There are very few people who are going to achieve a cure that's then they're going to be, let's say they're 30 years old, you get everything under control, and then at 90 years old, they're still fine. They're going to have events through the course of their life because there are going to be things that come up, especially women who might go through a pregnancy or children or whatever. Men have their own things that they go through. things happen. And so there's a good chance that something's going to come out again. And so I think that if we go about it, like, again, not super vigilant, like, oh no, I'm so worried that something's going to happen again. But if something does start to creep out, right, it's like, oh, yeah, okay, I get it. And then you just kind of try to reset pretty quickly. You know, maybe you catch it faster the second time because you know.
It's kind of having the right tools in the toolbox, isn't it? And recognizing the patterns as well, and understanding. And I think that's just the whole thing about understanding your body and what your triggers are and what's going to cause your symptoms to come back, and knowing how to manage those. That's a really important part of the whole picture. Okay, let's move on to some more questions. We've got Helen, do you want to come up?
Oh, well, I was going to combine this with a couple of other questions as well, actually. Okay. So thank you.
Great.
Just in regards to food in general, really, someone else has asked about leaky guts and the connection with MCAS as well. There's a lot of people who are quite extreme, that they really can't eat very much without getting a huge response. I definitely am one of those people as well. So any tips around introducing new foods without getting all the symptoms, and the correlation between, you know, leaky gut and also bowel movements and how that correlates as well would be really useful, I think. Thank you.
Yeah. So, you know, as I mentioned earlier, you know, there are many, many mast cells in the GI tract. And again, they're there to serve a purpose. But if they're overreacting and they're releasing these chemicals are really toxic to the mucosa, the lining of the intestines. They're toxic to us, right? So the mast cells are releasing chemicals. Let's say it thinks there's a virus there, and it's reacting. It then, you know, of course, then if it's so dysfunctional, it's going to react to the different foods coming in. It's going to react to a lot of things. And the chemicals that they're releasing, it's going to start to break down the lining, and the cells start to separate, and that sort of increasing intestinal permeability, leaky gut. So now, like, the cells are supposed to be pretty smooth. They're supposed to be able to absorb nutrients. So now there's like separation to the cells. So now things leak through, like food particles, which should not be going into the bloodstream, can leak through. Now the immune system is like even more overwhelmed because now it's seeing things that it shouldn't see because it should be staying in the gut. And so it sets up this really, really vicious cycle that can be hard to break, right? So the things that I think about are, again, look at the triggers. You know, if you have a parasite in your gut that you don't know about, that's triggering your mast cells. Mast cells are particularly sensitive to parasites. So, you know, if you treat the parasite, sometimes it calms the mast cells down, and then your leaky gut can heal. If you have an other type of infection in there, or you have dysbiosis, you have like too much bad bacteria and like not enough of the good bacteria, that will make, you know, the mast cells more reactive. So these are things that we think about. Sometimes we can measure some of the stuff in stool testing, try to get some clarity on like what may be, driving this. And then we start to work on it, right? So we're targeting the mast cells, trying to figure out what's going to calm the mast cells down in the gut. You can use different natural products to try to help, we'll call it heal the gut or heal the leaky gut. There are, sometimes we use digestive enzymes to help you break down the food so that the body, you know, is not so overwhelmed by that food. So sometimes that can be helpful when introducing a new food. But I think that in general, you want to introduce the foods when you've sort of figured out how to stabilize things the best you can. Because if you're really highly reactive and you're just determined to keep adding food and you're going to keep reacting, then you're just going to set yourself up in a loop. So you've got to step back. What's driving this problem? Why is the gut like this? You know, sometimes I have patients who wind up with, and especially after COVID, now I have a number of patients who have wound up with a colitis type picture, inflammatory bowel disease, from the initial viral infection that set up this cytokine storm and mast cell activation. And so now they really have leaky gut. They have like ulcers in their colon. And sometimes you have to stop the immune system. And sometimes it is biologics, but sometimes it's H1H2 blockers, and sometimes it's LDN. And again, everyone is different, but if you can stop that immune process and you can just sort of calm the mast cells down, then as the food then you can trial, the food and try to figure out, which foods are most important to get in, right? Which are the most nutrient dense that makes sense to introduce. If you're trying to introduce like rice, rice is, like empty carbs and not a lot of nutrients, and that's not going to serve you well. But if your problem is you realize that, say, you can't eat animal products, but we know that, animal protein is really, really important, then you're going to try to figure out how to get, maybe you start with, a grass-fed, type of, like, from a farm where it comes from, it's not aged, some kind of beef. It's sometimes complicated, but I think that the key is really that it's kind of backwards. You kind of have to get the gut a little bit better in order to deal with the food.
Thank you. I think this is a great question, actually. So it's about headaches. It seems to be a really big problem in the long COVID community, like constant headaches. And obviously that can be really multifactorial, but we do know MCAS is implicated in headaches. So how do you approach headaches?
Yeah. Well, we look at all the factors, right? So mast cells definitely can drive headaches. But like you said, it is multifactorial. There are other things that can drive the mast cell, that's driving the mast cell to react to cause the headache, right? So we always go root cause, like what is driving the mast cell? And if it's just, okay, it's a post-COVID thing and the body is in this cycle, well, then we got to break it. And so we're using mast cell targeted therapies, but sometimes we have to use therapies that are targeting migraines or cluster headaches, or, there are, we'll call them the neurologic drugs that they might have some mast cell stabilizing properties that actually also help to break the headache. So I think that headaches can be really, really tough to treat. There's no question. I have quite a few patients in my practice, and it's really just about, again, being systematic and running through, whatever you can, eliminating triggers. Again, if your home has mold, or there's something in your environment that you're sleeping in, that could be, I've seen that trigger. Mold is a big trigger for MCAS and for headaches. So I just want to emphasize that again, because I think it's something that people take for granted because they don't see visible mold. You may never see visible mold. The mold could be in an HVAC system, could be hidden behind a wall, and can be releasing mycotoxins. And mycotoxins are very, very, very minuscule compounds. They're toxins released by the mold. They're to protect the mold, so that they live. But many of them are neurotoxic. So they get into the nervous system and they set off the nervous system and cause headaches and lots of other neurologic symptoms. And they set off the mast cells. And so, I think that sometimes, looking for the mold, especially if there's been water damage that of, there's been like a leaky sink, or sometimes it's a really innocent thing, and it's not something that it's not like a major flood, but it's something simple that you don't realize could be causing a small amount of mold growth that then is causing a lot of mycotoxin release that then is setting off the mast cells, that's setting off the nervous system, and setting off the headaches.
Absolutely. We've got lots of questions to move on to, but on that topic, before we do, in regards to detoxing from mold, is there anything that you would recommend as a basic? And I guess that goes for parasites as well, actually, because it's quite controversial from my point of view as a patient.
Yeah. So again, I hate to say it depends. If you really need to get rid of the trigger first, right? So you don't never want to detox somebody if they're still living in mold, right? That's just going to be like bad, right? But let's just say you're in a clean environment, but you were exposed to mold at some point. You want to detox. There are different ways to do it. Sometimes we use various types of binders, they're called. And with MCAS patients, we have to do it very slowly and carefully and figure out which one is going to be tolerated. Sometimes people don't tolerate binders. There are some that I think are, some people do better with. They're gentler. Sometimes we use antifungal medication, especially if we think that the mold has caused or has contributed to an internal like yeast infection or mold issue internally. So there are lots of ways to do that. Parasites are a little bit different. Sometimes you have to use antiparasitic medication or antiparasitic herbs to kill the parasite. And then you detox, you try to get it to come out of you, so there are different ways to do it. And it is controversial in some ways. I just think that I like data, right? I tend not to treat patients. And again, I have it a little easier in the US and I realize that, but I do think it's good to test for parasites. And if you see the parasites, then and if you don't have parasites, I'm going to be a little more hesitant to throw parasite medication at you. For mold, it's a little bit harder. And, so you can sometimes treat a little more empirically, especially if we have a good history. And that's, what I do depending on the patient. And some patients do, well, and then over time they realize that they're getting less sensitive.
Great. Thank you. Moving on to our next question, and where time is going on fast. So we've get asked this a lot actually in regards to vaccine and the boosters. Valentina has asked, vaccine boosters had a negative effect on MCAS I developed after COVID. Is this a known phenomenon and should I avoid further boosters?
So I want to be very clear. I am, I'm not anti-vaccine at the least bit. I think vaccines are very, very important. But this is a very important point. Past performance often predicts future performance. So if you've had a reaction to a vaccine, to a particular vaccine, to the COVID vaccine, there's a very good chance you're going to react again, right? So I'm of the opinion that they probably should be avoided in that patient, right? I'm not giving medical advice, right? You need to talk to your doctor. But generally speaking, often, there's concern over a repeat effect. Now, it may be different with a different booster. In the States, I don't know about the UK, but there are now a couple different companies that are making it. Novavax, I think, is one that some of my long COVID patients have been okay with. Some of them who have had issues with the mRNA are okay with the Novavax, and they feel comfortable getting the booster because they are not reacting to that booster, So I think it depends, right? But I think that at the very least, if you know that you have a reaction to a vaccine, you need to be really proactive for future vaccines, even if they're different, right? So you want to be on as much mast cell stabilization as you can be on, maybe more before the vaccine, during the vaccine, after the vaccine. Maybe that's upping your H1, H2 blockers. Maybe that's doing more, right? You want to be in the best shape you can be if you need a vaccine. Sometimes you need the vaccine. But typically, if there's been a reaction, let's say to the COVID booster, we're more hesitant about that.
Yeah, and that's the exact advice I give as well, Tania, to my patients. If they've had an abnormal reaction to a vaccine, then I would encourage them to say, actually, let's think about a different way in which we can protect you rather than having this again, or let's think about something like Novavax instead. And I think that's just sound, sensible advice. Past predicts the future. It's a great way to look at it.
Yeah. On the flip side, a lot of us are not actually eligible. I'm not eligible. Should we be pushing to try and get hold of one?
Well, I think that's probably getting into another whole debate that we're probably not going to solve in the next couple of minutes.
No, but it's a good question.
Sadly. It's a great question, though. Should we move on to this one?
Yeah.
So this is about sort of antihistamine effect waning. So useful at the beginning with diphenhydramine, but then stopped working, and then no other H1, H2s had the same effect. Any reason why that might be?
Different population of mast cells that were released from the bone marrow that are just not as responsive to the diphenhydramine, right? Because I mentioned that, right? They every few years they change. I do have a subset of patients that develop a tolerance to the antihistamine. So they're taking an antihistamine, it's working for a while, and then I don't know, over time it stops working. And I don't think we understand that completely, to be honest, but I definitely have seen it. And so, then I encourage people to continue looking for agents. Maybe it's not going to be an antihistamine. Maybe it's going to be ketotifen or cromolyn or something else that's going to have a similar effect. And sometimes they take a break from the agent that they think it's not working anymore, like the diphenhydramine. They take a break and then they restart it again, and then they wind up like doing better with it again for a period of time. So, I think it's just a constant, kind of constant trial and error sort of thing.
Lovely. Helen, do you want to take this one?
Yeah, sure. So a question about what, I don't know how to pronounce it actually. So
gadolinium. Mouthful. Okay, so what do I think about gadolinium contrast risk for MCAS? So the thing is that in general, we don't know what an individual's mast cell is going to be reactive to. Like we wish we could predict that, and I'm hopeful that in the future we're going to be able to do that. We're going to be able to take people's mast cells out and like figure out what they're going to react to. So we don't know. I definitely have MCAS patients who have gotten gadolinium. They need gadolinium for an MRI study. It's a type of contrast often used for MRIs. They have a serious condition that needs gadolinium to see. The contrast allows you to view certain organ systems better. And we weigh risk benefit, and we say, you need it, so you're going to do it, but we're going to pre-medicate. We're going to do as much as we can. We're going to try to detox after the best we can, and get you through it. And I have plenty of patients who are fine. I have had patients that have come to me who, say that the gadolinium that they've gotten is what was the big trigger for them for making their MCAS worse. And in those cases, we continue to work on eliminating other triggers that may be contributing, detoxing, and then working on the mast cell. So it's definitely not unheard of, but it's not like at the top of my list to avoid, because I think you have to sort of weigh risk benefits.
Absolutely. Yeah. Okay, I think we're kind of just coming up to time. Helen, was there anything else you wanted to cover at all?
I mean, we've covered so much, and thank you, because it's difficult to follow, of course, when you're in the depths of any kind of chronic illness. So I hope that people have found this really useful.
No, I think that's been really, really helpful, and it's been a whistle-stop tour, because I think there's so much more we could have got into. We didn't even touch on Lyme and chronic infection and EBV, and I don't know if you've got like a 30-second kind of what's your take on the chronic infection. It's like, I feel like it's the Wild West, because we don't really know how to treat it.
What I would say is that I think there's almost no question in my mind anymore, after seeing so much of this, that COVID is affecting the immune system in a way that is allowing old infections to take root and surface. And so Epstein-Barr, herpes virus 6, other herpes viruses are commonly reactivated in patients with long COVID. And often those viruses need to be addressed as part of the treatment. And sometimes they don't need to be addressed because everything else gets addressed, and then the immune system kicks in, and then the body can respond, to them. So that's the viral part. The tick-borne or vector-borne infection is a little more complicated, but I have now a number of patients who didn't realize that they had these infections, got COVID, have long COVID, but have some residual symptoms that, while they seem like long COVID, it seems like there's something else going on, right? And we do the testing and we find some of these infections like Lyme or Babesia or Bartonella. And that, raises a question. Again, it's all immune related. And so it's about, okay, how do we approach that? Do we kill? Do we work on the immune system? Maybe a combination of both. But ultimately, I think the way I think about a lot of these things is that, like, we're the host, and lots of people are exposed to COVID, Epstein-Barr, Lyme. Like, lots of people are exposed to a lot of these things, and some people can handle that. The host can handle it, and for some reason, some people, their host body cannot handle it, right? And I think it's about that. If we can figure out beyond the mast cell piece, because I think the mast cell piece is huge, but there may be other pieces that we don't know about yet, right? That are, if we can figure that all out, then I think everything will make sense, right? And everything will be able to be addressed better and easier.
Yeah.
That's
that was amazing in a minute. So thank you, Tania. You did
Yeah.
really well there. But I think you've hit the nail on the head. I think just simply finding evidence that these bugs are there doesn't necessarily mean they're causing chronic infection. And it's how your immune system is responding to those. That's the important thing.
Mhm.
So that's a really great note to finish on. There's lots of love in the chat saying thank you and fantastic session and thank you very much. So I'll just echo that. We will be back in the new year. We've got some really great guests lined up. So we've got Dr. Lyle Yonker from Harvard, who's been doing some amazing research in long COVID in children. Dr. Peter Broden, who's an immunologist, and he's going to be talking to us about the immune system, how that goes wrong after COVID. And I've got an amazing doctor called Dr. Louise Oliver, who's going to be coming on. We're going to talk about breathing, 24-hour breathing pattern, and Buteyko and oxygen advantage, and why that can help with recovery. So please keep an eye out for the channel in the new year, and have a lovely Christmas, everybody, and stay safe and well. And we'll see you
thanks so
next
much.
year.
Thank you.
Okay. Hang on.